today. First of all, good morning, good evening, and good afternoon for everybody everywhere. And welcome for this month, August 2021 Journal Club of IPSRG. And today is with the Royal Medical Services Jordan, with Dr. Lamis, Dr. Hamza, Dr. Ghassan, and Dr. Muhammad. And we have two articles they will present consequently, inshallah. Just save time, we can start immediately. And before starting, I just want to apologize for everybody for the delay and some glitch, and we can start immediately.
Shall I start, Dr. Zia?
Yes, go on, Dr. Lamis, please.
Yes, please. Thank you very much.
Thank you, Dr. Zia, for this opportunity. We are a team from Royal Jordanian Medical Service, which is a military hospital in Jordan. It's actually a military center. We are 7 medical hospitals, military hospitals. Our center is Jordan Rehab Center, which is a center containing rehab, orthopedic, and plastic surgery. Our center for plastic, reconstructive, and burn, with big burn unit, reconstructive service of all types, and surgery, and microsurgery, of course. We are 16 surgeons of all levels. We have brilliant fellows, which we will present two of our fantastic fellows now, with two of our articles. Actually, our articles will seem a bit rare, but they are actually a problem solvers, because we encounter a lot of problems. We are actually a tertiary center, which usually all the problem from all Jordan refers to us, being the only tertiary center in Jordan. So actually we see all the rare cases in Jordan. So we wrote those articles describing one of the cases that few of the cases of that all of us as plastic surgeon will see that's difficult to handle. We'll start now with Dr. Abne, he's one of our brilliant fellows, describe a race of avulsed ear, and was referred to us from private hospital after 22 hours actually, and alhamdulillah we managed to save this year, and he will describe in details how the protocol that we followed to save that years. So Dr. Hamza, you can start now, please.
Thank you very much, Dr. Lamis, for that nice presentation. I want to share my screen. Can you see my presentation now?
Yeah.
Yes, we can. Thank you.
Okay. First of all, I would like to thank you for this opportunity to join you in this club. This is my first time actually in the International Plastic Surgery Group. Thank you, Dr. Lamis, for that nice presentation. And thank you, Dr. Karachi and Dr. Salah, Dr. Hala. Dr. Muhammad Abdur actually with us here is our mentor, consultant plastic surgery. That article that was published by him and our colleagues, it's about a non-microvascular successful management of a near total avulsion, ear avulsion. This is the case report that was published in the PRS Global Open. The author has no financial interest to declare in relation to the content of this article, and a verbal consent was taken to present the case in the IPSR Journal Club. Those are the authors, Dr. Muhammad Abdur, consultant plastic surgery, and our colleagues. And introduction about the case. As you know, traumatic ear avulsion represents a difficult challenge for all of us as a reconstructive surgeons. Hence, replantation and reattachment will provide the best aesthetic outcome. However, when microsurgery is not possible, the surgeon must choose the most appropriate alternative method to address the concern. Traumatic ear injuries, actually, it is when the auricle is lost, it's liable for extreme imbalance of the facial contour and interference in the patient's life because of social fear and stigma. Due to the area and position of the external auricle, are prone to outer injuries by trauma. It could be a simple laceration up to the crushed injuries. It could be a partial or even total avulsion amputation. The outcome of a reconstructed ear after the injury has highly affected by the primary immediate management of the injury during the onset of trauma. It starts actually in the emergency department, the initial decision in the emergency department. So what are the options for traumatic ear avulsions for treatment? Those are non-microsurgical options, and there's microsurgical options. About non-microsurgical options usually involves burying or banking the cartilage in the temporal scalp, abdomen, or volar forearm for delayed reconstruction. Many techniques, as you know, have been described for non-microsurgical options, and the results are inconsistent, and the cartilage loses its definition over time and becoming flattened and dragged. Those are different non-microsurgical options explained in the literature. But recommend removing the posterior skin from the amputated segment, fenestrating the cartilage to allow for a greater imbibition and new vascularization, and then it's covered by a post-auricular flap divided 3 months later. Maldek recommended dermabraiding of the amputated segment, reattaching and burying beneath retroauricular skin. 3 weeks later, the reconstructed ear was removed from its pocket and denuded areas eventually reepithelialized. Destro and Speranisi recommend removing the skin from the amputated segment except for the concha and made small round perforations in the cartilage, and the cartilage is covered with a post-auricular flap and division after 3 months. Park recommended removing all the skin except for the helical rim. The cartilage then sandwiched between 2 flaps, posterior one based facial flap and anterior one skin flap, and the skin on the helical rim later necrosed but salvaged with additional operations. You will find a lot of techniques for total ear avulsion, and they all explain a different technique. Everyone has its pros and cons. Those are the what about microvascular replantation? Actually, microvascular replantation still is the best for total ear avulsion, because it allows the ear to restore its form, and the cartilage loss in non-microvascular options is better, or actually the cartilage can survive. So it's technically demanding, as you all know, because the small caliber of the vessels, and often venous outflow is the problem. Microvascular anastomosis is performed to either the post-auricular artery or the superficial temporal artery. Both can restore blood supply because of the interconnections between those 2 arteries. About the case that was presented by Dr. Mohammed Abdur in Jordan, he's a 55-year-old man with no significant past medical illness, presented to the Royal Rehabilitation Center in the Royal Medical Services Jordan with avulsion of right external ear caused by a motor vehicle collision. The patient was initially managed in a private institute by simple suturing of the avulsed ear without cartilage repair and local wound dressing. Few hours after the procedure, the ear started to develop signs of venous congestion. The patient then referred to our center 22 hours after the initial injury with signs of severe venous congestion. This is the picture at time of injury. As you can see, the ear is totally avulsed with only attached to a small 5 mm skin bridge from the superior helix. This is 24 hours post simple suturing in that hospital with signs of severe venous congestion. Emergency explorations was performed to the patient. The patient was taken immediately to the theater, and the entire external frame was avulsed, crushed, and attached only by a small skin bridge, which is about, as you can see, it's 5 millimeters from the superior helix. The ear has a satisfactory arterial blood supply, but shows signs of severe venous congestion. The procedure, intraoperative proper wound washout with the repair of the cartilage was done, and the ear was reattached by skin closure, anatomically, followed by aggressive rewarming and initiation of a low molecular weight heparin protocol was implemented. Due to the lack of adequate veins to perform microvascular anastomosis, it shows signs of severe venous congestion. All the possible management solutions were discussed with the patient, and the use of local heparin injection therapy was acknowledged. Multiple small incisions with 11 blade on the venous congested area of the external auricle were done, along with the rewarming cycles, followed by subcutaneous and intradermal low molecular weight injection, and then gradual tapering postoperatively. This is the protocol actually that was implemented from the first operative day up to the 11th day, with a gradual tapering of the dose of low molecular weight heparin, starting from 4,000 international units per day with neomycin sulfate impregnated gauze dressing. On the 4th day, 3,000 international units per day. On the 7th day, decreasing the dose to 2,000 international units per day and dressing once daily. In the 10th day, injection of 1,000 international units with neomycin sulfated gauze dressing. And from the 11th day, the low molecular weight heparin stopped as resolution of venous congestion achieved. This table actually from one of the literatures that explain the use of low molecular weight heparin in free flaps, and it divided the free flaps according to the surface area. If it is less than 75 square centimeters, or if it's more than 75 square centimeters. The dose depending according to the surface area, gradual tapering of the dose up to 2 weeks. This is on the post-operative day 6. You can see the signs of venous congestion is almost resolved. Small stabbing incisions in the skin for drainage, and another corrugated drain was placed posteriorly for drainage. The dressing technique was conducted every day through warm saline gauze to induce vasodilatation and neomycin sulfate impregnated with the dry dressing to keep a moist environment for wound and to prevent desiccation. Small superficial epidermolysis over the condylar skin that was managed with dressings and oral antibiotics. The amount of bleeding is very important when managing with low molecular weight heparin. It's observed daily on the dressing, and the amount of dressing soakage noticed to be decreasing by decreasing the dose of local heparin injection. Of course, you should follow up the patients with daily complete blood count and observe his hemoglobin level. The patient has no significant drop in his hemoglobin. This picture in the follow-up in the clinic after about 6 months. Of course, the patient was discharged on day 12 with satisfactory outcomes and complete healing of the external ear. So, as we know, a venous congestion of a free and regional flaps is a common and described in the literature that low molecular weight heparin has been used effectively to treat flap venous congestion according to the surface area, because its bioavailability and intermediate half-life, which ranges about 4 to 7 hours, and dose-dependent clearance. So in the case, Dr. Mohammed applied same concept and considered that case as a congested flap with less than 75 square centimeters. The use of low molecular weight heparin has been described in the literature for treating venous congestion for years with a satisfactory outcome, actually. So what about medicine leeches versus low molecular weight heparin? Medicine leeches are used in practice nowadays for early salvage in cases when microsurgical anastomosis and anastomosis of venous outflow cannot be achieved, or if there's a vein thrombosis. On the other side, it has some cons. It can cause infection. So it's a very common side effect for using medical leeches, and especially on the ear, because infection of the cartilage will lead to cartilage framework loss. So a complete blood count should be monitored, as we mentioned, and RBC transfusion should be promptly administered when needed. Blood loss can also be a complication, actually, with the use of the heparin. This is a picture I looked for on the internet for the use of medicinal leeches. So in the case, we achieved successful survival of near total avulsion. No need for any blood transfusion or increased risk of wound infection by the use of medicinal leeches. Simple application of subcutaneous and intradermal low molecular weight heparin, which we can consider it as a pharmacological leaching in a form of protocol with regular wound care. In conclusion, subcutaneous and intradermal low molecular weight heparin and the proper wound care can be used effectively in cases of severe venous congestion of the avulsed ear with adequate arterial inflow without causing any morbidity to the patient, and can be applied even after microsurgical arterial repair with no venous outflow. Actually, we tried low molecular weight heparin in our center. Dr. Mohammed Dur has been using this technique in different cases in organs, avulsions, or fingertip injuries with a satisfactory outcome. This is the link for the article provided. I would like to thank you very much for this opportunity. I will leave the questions for the last. I don't know, Dr. Labis.
Yeah, thank you very much. So, should we have questions now? Lamis, what do you think? Should we have questions now or at the end?
If you like, we'll have some, we'll talk to to our mentor, Dr. Mohammed Abdur.
Yes, sure.
Who's our research director, Dr. Mohammed Abdur.
Welcome, Dr. Mohammed Abdur.
Hi, Dr. Mohammed Abdur.
Hi, good evening, everybody. And thank you for this opportunity to join this great webinar. I hope hopefully we can continue this great scientific opportunities in the future. So hi to everybody, and thank you very much for the invitation.
It's a pleasure.
Thank you, Dr. Mohammed, and we would like to thank you on behalf of our RMS and for letting us have this amount of research in your name. And we'd like to ask you a question. When you start to notice the difference and to feel that your method is getting some success, in which day exactly? Because in the article, you say that the clinical evidence was in the 6th day. So you waited 6 days in order to have some clinical and some obvious signs that your method is working. But I think you have a gut feeling that it was going to work, and earlier than that. So the first sign that you noticed that it's working was in which day?
Thank you, Lamis. The first sign is the improvement in the venous congestion.
Yeah.
And actually this happens after the restoration of the venous channels, which happens actually around the 5th day. After the 5th day, there is a restoration of the venous channels, and we started to reduce the low molecular weight heparin intradermal and subcutaneous injection as in any venous congestion. Then the actual or the final improvement actually after the 7th to 10th day, when there is a restoration of the venous channels and the formation of new venous channels. At that day 10 to day 14, we started to wean the use of low molecular weight heparin injections, and we discharge the patient.
So it got you a lot of persistence and patience to pursue the method every 4 hours for 5 days, continuous 5 days.
Yes.
Did not get challenged by those, but no,
Yes.
by no signs at all till the 5th day.
Yes.
So there's a question: how did you decide that it was a venous congestion, not an arterial supply, which was the problem?
Yes. As presented, thank you, Hamza, for your nice presentation. As presented by our colleague, Dr. Hamza, it is a complete ear avulsion, near total ear avulsion with a crushing injury. So at the first exploration, only 5 millimeter skin pedicle is attached. With the initial exploration, there is an inflow, arterial inflow, but there is no outflow. When we attempted to try a when we attempted to try a venous anastomosis, due to the nature of the trauma, it was a crushed trauma. There is no good veins to anastomose. All of veins are crushed, and all of the tissues are crushed. So venous anastomosis at that time was not possible. And I think this article will put the basis for management. As we know, any reimplantation of a special organ, nasal reimplantation, ear reimplantation, and all of these facial special structures, the main problem, even after reimplantation, is venous congestion. And the cause of failure is venous congestion. And the solutions for venous congestions, as we know, not in all parts of the body, the medicinal leeches are available. So this idea, which we get it from management of free flap venous congestion by intradermal and subcutaneous low molecular weight heparin, is very helpful in trauma cases, as we use this in our case, and give the basis for pharmacological, it is called it pharmacological leaching as effective way of management of venous congestion.
Okay, thank you. Thank you for explaining that crucial point. So, Doctor, do you think that we should pursue to the next article?
Yes, I think we should, but thank you. We can start now.
So now we'll invite Ghassan. Ghassan is another active fellow for our team. He's a fellow of plastic and reconstructive surgery. He's a captain actually in our institution. He will be talking about 2 cases in nasal, challenging nasal reconstruction. So the floor is yours, Ghassan.
Thank you.
Yeah, you can share it.
Is my screen clear?
Yeah, it's clear.
Yes, it is.
Yeah,
thank you very much for this nice opportunity to present these 2 challenging cases for special aesthetic subunit nasal reconstruction. All in all, I will start my talk about a brief talk about nasal reconstruction to set the basis for our case reports. So, is nasal reconstruction a challenge? As we all know, nasal reconstruction is really a very big challenge. Due to many factors, mainly the social stigma of nasal defects. The patient present a huge challenge for the reconstructive surgeon to achieve the good results that are possible today. Through the ages, nasal reconstruction has followed a slow but regular improvement due to advances in techniques and closer attention to details. So globally, reconstruction of the nose can often require multiple stages of surgery and revision to achieve the desired final surgical result. The main point is the preoperative planning, and it is a very important aspect for successful reconstruction. A brief anatomical talk. The nose grossly consists of 3 layers, starting by the external skin, the mid layer of bone and cartilage, which are the support for the nose, and the lining, which is largely mucoperichondrium. Also, it's divided into thirds, which are called vaults. The proximal one, which lies over the nasal bones, the middle lies over the upper lateral cartilages, and the distal includes nasal tip with a paired ala over membranous septum. The columellia is supported by the medial crura of alar cartilage, and it's very important because it is a special aesthetic subunit of the nose. Regarding the skin of the nose are divided into two thirds, two upper thirds, which are characterized by being thin, loose, and mobile with few sebaceous glands, and the lower third, which is thick, less mobile, and contains more sebaceous glands. The zones of thin skin are the dorsum and columella, and the zones of thick skin are the nasal tip and ala. The nose can be divided into 9 aesthetic subunits, and they were described by Berget and Mennick, which is the dorsum, the tip, the columella, the paired side walls, the paired ala, and the paired soft triangles. Reconstruction of whole subunits may produce better aesthetic results. The special aesthetic subunits, mainly the columella and the paired ala, they are special because they are cylindrical, layered. They have a cylindrical layered morphology with a peripheral location. Columella and alar margins are difficult to reconstruct. Regarding the case reports, I will present 2 case reports where we used chondrocutanuous grafts. The first one is about a male child who presented to our clinic with a prolonged use of nasal CPAP in the neonatal ICU during neonatal period, which resulted, as you can see, in columellar necrosis. On the examination, there was total loss of columella and anterior nasal septum. Looking at the photos, when we look at the site and size of the defect, a plan was made preoperatively to reconstruct the defect in a single stage operation, and this is very important, in a single stage operation. A composite chondrocutanuous graft was taken from the ear root of helix, as you can see in the first photo. The composite graft was sutured to recipient defect after recipient bib preparation, and the donor side was closed primarily. The follow-up photo. The take of composite graft was adequate with good correction of defect, and donor side healed completely with minimal donor side scarring. The second case report is about a 28-year-old female patient who had a history of childhood postnasal trauma, left alar rim defect, as you can see in the first photo. Also, preoperative planning started, and a decision of single-stage surgery was made to restore the alar rim. A chondrocutaneous graft also was harvested from the root of helix. In the follow-up visit, the take of composite graft was excellent, and restoration of alar rim with good contour, color, and texture match. The donor site also healed with no significant scarring. So, for nasal reconstruction, the reconstructive ladder ranges from healing by secondary intention up to local and regional flaps. Our options were, especially depends on the size and site of the defect. So for small superficial defects, they can be left to heal by secondary intention, or they can be closed primarily. Full thickness skin grafts could give a good result in the upper 2/3 of the nose, where suitable donor sites include the forehead, the preauricular, and the supraclavicular areas. Composite chondrocutaneous grafts from the ear helix can be used for alar rim and the columellar reconstruction. Local flaps for the nose are limited to 1.5 to 2 centimeters defect, such as transposition flaps, mainly banner flap, bilobed flaps, rotation advancement flaps of the nasal dorsum and glabella, and mainly the nasolabial flaps. For larger defects, the nasolabial flap can be used as 1, 2, or more stage procedure. The paramedian forehead flap is considered the gold standard, and it has been refined and described in detail by Mennick. It gives an excellent texture and color match, and it's usually pedicled and the medial eyebrow based on the supratrochlear vessels. It could be transferred in 2 or 3 stages. Any donor sites that cannot be closed could be left to heal. If forehead skin is not available, we have the major reconstruction method, which is free flap. So as an example, healing by secondary intention, as you can see, pointing, where is the arrow pointing? An alar defect which was left to heal by secondary intention, and the resultant scar is often depressed and shiny. Regarding the case report, for reconstruction of nasal columella and alar, many literatures described regional flaps such as nasal sulcus flap, forehead flap, and nasolabial flaps, but all, as you can see in the photos, will add more scars to the face and undesirable aesthetic outcomes. For reconstruction of nasal columella, many literature describe two loco-regional flaps, such as the nasal sulcus flap and the forehead flap and nasolabial flap. But as you can see, described in the photo, all will add more scars to the face and undesirable aesthetic outcomes. This is a description of using a nasolabial flap for lateral alar defects. As you can see in photo A, we can see that there is a defect shown with minimal intervening tissue between it and the planned flap, which is shown in B, photo B. Photographs are shown demonstrating the flaps immediately after NSAIDs, C, and long-term results, D. Also, this is a two-stage nasolabial flap reconstruction for lateral alar defect without completion subunit excision. As you can see, the defect is shown in A, and immediately by the first stage photos were taken, shown by B and C. D after the second stage division of the flap, and E is the final result or follow-up result. For columellar reconstruction, nasolabial flaps, we could use bilateral flaps which are tunneled or rolled inward to line the vestibules and create a central post. We could use upper lip forked flaps as an option. They are transverse flaps forked from the upper lip, either used unilaterally or bilaterally. Vestibular flaps, transfer of internal nasal vestibule skin flap combined with bilateral labial mucosal flap. And the benefit of using this flap is that we don't have external scars. Forehead flaps, mirror technique prefers extension of the forehead flap to reconstruct the columella. And at the end, the chondrocutanuous grafts, which are, as our case reports, they are auricular composite grafts, which could reconstruct the superficial columella, which could be used in reconstruction of superficial columellar loss in elderly patients with long-lipped patients. As you can see, composite chondrocutaneous grafts was described in many literatures. The graft was harvested from the helix margin, concha, and this gives traditional wedge shape of two skin layers separated by cartilage. In our case report, we harvested the composite graft from the root of helix, which gives composite graft of cartilage covered by skin. Besides, it gives better aesthetic outcome and hidden donor side scars. Many authors, especially for using chondrocutaneous grafts, described that the graft size should not exceed 10 millimeter in diameter for the graft to survive, as if it exceeds 10 millimeter, success rate significantly decreases. Composite grafts with more than 15 millimeter has a chance of survival of less than 50%. In our cases, all composite graft size was less than 10 millimeter. So as a conclusion, helical root chondrocutaneous composite grafts can produce desirable aesthetic outcomes, and they should be considered in patients presenting with traumatic or iatrogenic loss of columella and alar rim. Thank you very much.
Very nice presentation, Hassan. Very precise and very educationally high value.
Thank you very much.
Dr. Ghassan, I have one question. Do you replace the whole aesthetic unit or just putting the graft for the defect only? Replacing the defect?
We replace the defect with the composite graft.
But at this time, you will have a scar at the convexity of the ala. And you know, any scar at any convex area will be showing and liable for, if any contraction, it will be showing
I will try to go back to I will share the screen to go back to the photos to look at the final result, if you allow me to do that again.
Sure, sure.
I think in this particular patient, we were lucky that the defect was not in the convexity of the ala exactly.
Yes.
Dr. Yeah. That's help in taking the decision.
So as you can see.
Yeah. So if the defect was exactly on the convexity of the ala, I will agree that we should have replaced it all of it. But the type of the defect help us to take this decision. We were lucky.
Yes. Yeah. In your cases, did you face any like trapdoor effect or lymphedema of the grafted area or something like that?
Actually, this was my patient. I advised the post-operative management helped us to avoid this. We advised her starting with the third day of the surgery to start the massage with the. We first apply a pressure dressing using the stir strips, and then we do the light massaging. So luckily everything went very smooth, and even the scar. I have maybe Ghassan, I have maybe you have more advanced photos to her that this hypertrophic scar was gone, and you know, I was so afraid that that she will have some defects after some resorption of the scar, the cartilage, but luckily everything went smooth, and I think we got lucky, and she was lucky to have this. I think the planning was a slightly extra skin, that with the resorption everything went smooth.
Did you try to make like inner slit from the inside of the nose and put the composite graft only skin and
it was double layered? Actually, it was double layered inside out.
No, I was asking about to make it single layer, making inner slit like a slit and making it like oval, then put a oval piece of skin with a cartilage inside from inside to make lengthening of the rim of the.
Can I answer this question, Lamis?
Oh, of course.
Thank you, Lamis. Thank you for your question. It was published in BRS, I think, before 5 or 6 months, a paper talking about the chondrocutanuous grafts with multiple series of patients, and they were harvesting the cartilage and the skin in a composite way in 3 layers and harvesting it from the posterior concha. These cases we did them before we read this article, before this article was published, and our choice was the helical route because it supply us with the cylindrical 3 layers that we need them in nasal reconstruction. So it was helpful for us in the rim, alar rim, not for the ala, it's for the alar rim and for the columella reconstruction because of the peripheral position of columella. So it was perfect for us for the peripheral positions of the constructed subunits and provide the 3 layers. Of course, for your question, the bed preparation for the composite graft take is very important. So in the case of columella and in the other case of alar rim, we sandwich the 3 layers in a pocket that was made in the first case at the bed of the missed columella and missed anterior septum, and in the other case at the site of missed alar rim.
Thank you, Dr. Muhammad. Thank you so much. And thank you, Dr. Ghassan.
Dr. Muhammad, there is another question. They ask about the maneuver you did for the recipient side. Any turn down or any type of flaps created for recipient side?
Yes. Actually, for the columella case, actually it was published in details in PRS. in another article that's describing a series of cases. The whole technique was described for preparation of the bed and to put this composite graft in well prepared bed that sandwich this composite graft.
Any other question?
Yes, Dr.
Yes,
Muhammad.
I have a question, if I may.
Go and say.
Excellent. In my opinion, this is an excellent result, and I cannot think of any other way that it could have been improved. I think these composite grafts are pretty tricky, and getting them to take is a hard job. And I would like to know if you have any other tricks to make these grafts take. It's not easy, I know that. These composite grafts are very tricky. And if there is anything else you would like to share, how to make sure that these grafts take. Do you heat them? Do you make them cold? Do you immobilize them? What do you do? Can you please share your ideas about it?
Thank you for your question. To summarize the important tricks and hints in this procedure, the first, as Dr. Ghassan mentioned, is the size of the graft. The size of the graft, if it is composite and if it is from the auricle, should not exceed 1.5 centimeter. And the best survival of these grafts is under 10 millimeter. All of our grafts that we harvest is less than 10 millimeter. The other thing is good preparation of the recipient bed to receive the graft in a way that we pocket these grafts in a well-vascularized bed. Good fixation, as you mentioned, dear doctor, good fixation of the graft and to prevent shearing forces and immobilization of these grafts. Good wound hygiene and good wound care after that. Some papers and some literature talk about the warming and light to increase the uptake. But in our experience, we use a lot of these composite grafts. If the size is less than 10 millimeter with good wound hygiene, well preparation of the bed, and good fixation and immobilization, they have a near 100% successful rate.
Thank you very much. I think these are very useful tips. Thank you for sharing your cases and your experience.
Dr. Muhammad, please, for our junior, because regarding the ear case, because you know this is the advanced technique. What is your advice for our junior? Because they cannot proceed for such, if you agree with me, they cannot agree for doing like that, keeping the ear and waiting for the response of the congestion. And he can lose, as you said, if you have any infection or something like that, you can lose the whole framework. Can you advise them for the alternative if they don't have microvascular to reconstruct? How to preserve the cartilage? You had the other option, local option to do like that. Can you advise them, please?
Unfortunately, we have not that much number of patients of traumatic ear avulsions because we are a small population. But from our experience, you have nothing to lose. Anything else that you will do will be unsatisfactory. As Dr. Hamza mentioned, the best solution is microvascular reimplantation. If it is not available, whether due to the settings or whether due to the nature of the trauma, as we know, nasal reimplantation and ear reimplantation is very difficult. And even after successful reimplantation, always the problem is in venous anastomosis and in venous congestion. So it's a great challenge for the plastic surgeon. So in the cases of ear trauma, you have nothing to lose. All the other things that we tried in the past, like bucketing the amputated ear in the abdomen or in the scalp, or debriding or removing the skin and reposition of the auricle in a subcutaneous bucket or as a composite graft, all of them will give unsatisfactory results because of resorption and rubbing. And rubbing, we noted it when we started to put these auricles, amputated auricles in the abdomen, in the subcutaneous pocket. So the best, as I mentioned, the best is microvascular implantation. If it is not possible, you can do composite grafting in the auricle from our experience. And if you have a good, if you have a good, as in this case, we are lucky to have a good arterial inflow, but we have no venous outflow. The use of topical low molecular heparin was very safe. We know that the more dangerous protocol is to use it in a systemic way. In a systemic way, it will affect the whole body. But if you use it topically, intradermally, and subcutaneously, in fingertip injuries, such as our case with venous congestion, it's safe with serial PCV and serial monitoring of the patient.
I was talking about depithelialization or removing the skin or removing the epidermis and putting temporoparietal fascia to cover immediately.
We didn't try this actually in our center, and I did my fellowship with the Professor Zhang Changchen of Taiwan. He is a well-known, famous microsurgical surgeon and ear surgeon. We have a discussion about these ear traumas. The best is microvascular implantation. All the other things, such as removing the skin and the epithelialization of the cartilage and use of subcutaneous pockets, of course, it gives a result, but it's an unsatisfactory result.
I know. I know that the gold standard is to do microvascular, but I mean, if it is not available, and at least I can preserve the cartilage framework, because it's the most important, the cartilage framework, because you will not be able to.
Can I give my 2 cents on this? I have some experience in this area. There are 2 big no's in treating these ear avulsions. One is we try not to destroy the local skin by trying to bury this cartilage. This cartilage framework is very flimsy. It's not as strong as that we use from the ribs. So trying to bury it flattens it out completely, and it also destroys the local post-auricular skin, so that in future the chances of doing a ear reconstruction, they are diminished. As for the temporoparietal facial flap, this is like gold in this area. This flap is extremely useful in ear reconstruction, and losing it on a framework might not be a good idea, because this framework, which is already damaged and crushed, it's a very thin cartilage originally in the ear. When we try to reconstruct the ear, we make a very heavy, solid frame to withstand the forces of contracture. I have personally tried burying in the forearm, not a great result. Burying in the post-auricular area destroys the post-auricular skin. I have never tried the TPF, because I feel that TPF is something that is very, very important and not to be used unless it is absolutely necessary. But I'm open to suggestions from the masters.
So I have one question, Doctor. You mean that TPF, you should leave it for the last choice, I think. You will not use your TPF as a first choice during reconstruction of the total avulsion there, right?
I would not use it in a damaged ear. I would rather reserve it for the future ear reconstruction.
Definitely, yes.
Using the costal cartilage.
Actually, Dr. Salah, in that case in particular, as we all see that the patient has only a 5 millimeter skin bridge. Without that bridge, that management will not be successful actually. So the problem was only in venous outflow. So other options in that case in particular, that in burying in the forearm or the temporal area, would be too invasive. You will possibly lose your framework, and actually keeping the ear in its original place. And as Dr. Muhammad said, you have nothing to lose. You have the inflow, but you don't have the outflow. So using low molecular weight heparin to drain the congested blood was a good choice at that time. And the patient has satisfactory results with a good healing process, and the ear framework still there, and the patient didn't actually needs additional surgeries to reconstruct his ear.
I agree with you. It's a very successful case, but I mean, this is not the rule, because not all cases that you resuture and keep it in place, giving a chance they will survive the congestion. You know, congestion is enemy and disaster for any microvascular, any compromised tissue vascularity, and so on.
Yes, for sure. Yes.
Nothing succeeds like success.
Exactly.
Yeah, exactly.
Dr. Salah, I think that seeing the artery is active, that gives the push to go and do this adventure.
Yeah, I agree.
So I think this is the main key that led us to this adventure.
That's very important. Did you see an artery in that 5mm tag?
Yeah.
He's very lucky.
That's fantastic. I think that was a very, very wise decision.
Yeah. So I think this is the key factor, the key word in this adventure, also the active artery. So it's worth a try. Another question from Dr. Fatima Youssef to Dr. Muhammad regarding the first case about complication of cold intolerance after ear implantation. Have you ever encountered this complication?
Thank you for this nice question. Actually, I followed my patient for the last 2 years. There was a minimal scarring. The most important thing, actually, to mention that there is no resorption. Even after months of this procedure, there was no resorption in cartilage, just scarring at the site of the trauma. And there was no complaints regarding sensation or hyperesthesia or cold intolerance. He was okay.
That's good. So have you ever encountered in all those trauma, you know, that we have many cases of traumas, any patient who come complaining of cold intolerance? I think in finger, we do a lot of finger implantation. Yeah, we very have complication all the time. But in ear, have you encountered this complication?
We have only this case, so I cannot judge. My patient was fine.
So we have this complaint all the time.
But we see it a lot in composite graft in fingertip injuries. Yes, it's a very common.
Yeah, I guess it's less, since the nerve ending in ear is more fine than the hand. So I think this complication might be less. Yeah. Another question of Dr. Farouk. Would you do this protocol again and again? I think we answered this question. If you see a good caliber artery that worth taking this adventure, just go ahead and do it. Yeah.
Yes, go for it. Yeah. Definitely.
Any other question?
Shall we wrap this session?
Yes.
Hi. Did you hear me?
Of course. Hi, Hala. We miss you.
Sorry. Yes, I would like to say something. Thank you so much for the Jordan team. First, Professor Dr. Muhammad, and my friend Dr. Alimi, and Dr. Hamza and Dr. Ashan for the very successful, interesting session from our International Journal Club series. And really, I really enjoy, and I'm so happy to be with us.
Thank you for your advice.
Thank you for all the audience that accept our invitation to be attend today, and also for my team, Dr. Zia and Dr. Salah, and all others. Thank you.
Thank you for giving us this opportunity. Thank you.
Thank you, Dr. Hala.
Thank you very much.
Thank you very much.
Thank you.
Thank you.
Let's Dr. Zia, Dr. Salah.
Thank you, Dr. Hala. I have to go actually because it's Maghrib prayer before Aisha. For closing, I would like Dr. Lamis, Dr. Hamza, Dr. Ghassan, and Dr. Muhammad, and all our audience. And also, I would like to apologize for whatever happened today for a technical problem. It was out of our hands. And inshallah, see you after 1 month, last Tuesday of September, with a new session of Journal Club. And thank you, everybody.
Thank you.
Thank you.
Thank you.
Bye.
Bye-bye.
Bye. Bye.
Very well done, Team Jordan.
Bye-bye. Thank you.
Thank